Dear colleagues, it is my privilege to welcome you on the annual conference of the Emirate Society of Internal Medicine. In the very last moment, I expected to be with you on site, but unfortunately, unexpected circumstances did not allow me to do that. The topic of my lecture today is the news from the Congress of the European Society of Cardiology that took place in Barcelona just a month ago, both on-site and online. And the audience of the Congress was almost 20,000 participants. As all this, it was full of the most recent scientific and also practical advances and achievements in the field of cardiology. And I prepared very brief digest of the news. So, four new or updated clinical practical guidelines were presented during the Congress. The guidelines on cardio-oncology, on cardiovascular assessment and management in patients undergoing non-cardiac surgery, management of ventricular arrhythmias and the prevention of sudden cardiac death, and pulmonary hypertension. The guidelines on cardio-oncology, it was the first ever document in this area, and guidelines were developed in collaboration with the European Hematology Association, European Society of Therapeutic Radiology and Oncology, and the International Cardio-Oncology Society. The document contains 272 recommendations, and the main parts of the guidelines belong to the definition and risk stratification of cancer therapy-related cardiovascular toxicity, prevention and monitoring of cardiovascular complications during cancer therapy, diagnosis and management of acute and subacute cardiovascular toxicity in patients receiving anti-cancer therapy, end of cancer therapy, cardiovascular risk assessment, long-term follow-up and chronic cardiovascular complication in cancer survivor, and also discussing the aspects in special populations. And the central illustration from these guidelines showing the dynamics of cardiovascular toxicity risk of patients with cancer over their treatment continuum. The guidelines on cardiovascular assessment and management of patients undergoing non-cardiac surgery are the updated version of the guidelines approved 8 years ago and contain 89 recommendations what to do and what not to do in such cases. The most important chapters of the document are dedicated to clinical risk evaluation, preoperative assessment tools, general risk reduction strategies, specific diseases, preoperative monitoring anesthesia, and also perioperative cardiovascular complications. And the central illustration showing the complex interplay between the intrinsic risk of surgery and the patient risk of perioperative cardiovascular complication. And I know today you will have one more lecture on this issue, so I will not focus too much of your mind on this document. Guidelines for the management of patients with ventricular arrhythmias and the prevention of sudden cardiac death were also updated since 2015. There are 160 messages what to do or not do, and the document discusses the definitions, preoperative assessment tools, epidemiology of sudden cardiac death, and risk stratification, general aspects of therapy and evaluation for ventricular arrhythmias, diagnostic evaluations, management, risk stratification according to clinical presentation and likely known disease, and also discussing special aspects in selected population. And the central illustration of these guidelines showing the generic risk, genetic risk and typical triggers for ventricular arrhythmia and sudden cardiac death, age and presentation of these outcomes, gender predominance, and typical type of ventricular arrhythmia, different diseases associated with ventricular arrhythmias and sudden cardiac death. And finally, the guidelines for the diagnosis and treatment of pulmonary hypertension were developed in association with the European Respiratory Society. And it is also the updated version of the guidelines and include 114 guidelines, recommendations, what to do or not to do. There are the sections in this document discussing the definition of the pulmonary hypertension and its classification, epidemiology, risk factors, diagnosis of the pulmonary hypertension, and very precise discussing the groups, the subtypes of pulmonary hypertension, and different aspects of the management of the patient with the different subtypes of pulmonary hypertension. And the central illustration showing the prevalence, clinical classification, and therapeutic strategies in different groups of pulmonary hypertension. I just will remind that we still have 5 same groups as we had in the previous version of the document. For those of you who became interested in these guidelines may find and upload the full text of the documents on the official website of the European Society of Cardiology. And on special hotline session of the Congress, the results of the most valuable trials and meta-analysis were reported. And here is the top 10 of them due to my personal opinion. So in the SECURE trial, the treatment, which contains a polypill with aspirin, ramipril, and atorvastatin, during the 6-month follow-up after myocardial infarction, resulted in significantly lower risk of major adverse cardiovascular events than usual care with prescribing of the same medications separately, mainly because of the much better compliance and adherence, medication adherence in patients taking the medications. The time study showed that among the patients with arterial hypertension, the timing of blood pressure medication does not affect the incidence of adverse cardiovascular events. So the patient can take antihypertensive drugs in the morning or in the evening according to their preference, and there will be no serious influence of the regimen of medication taking on efficacy or safety of the blood pressure therapy. The revived CIS study showed that among the patients with severe ischemic left ventricular systolic dysfunction who received optimal medical therapy, revascularization by percutaneous coronary investigation did not result in a lower incidence of death from any cause or hospitalization for heart failure, comparing with the optimal medical therapy. So it's again raised the question, do we really need a routine percutaneous coronary intervention in patients with stable ischemic coronary heart disease, and in this particular case, in patients with severe ischemic left ventricular systolic dysfunction. In the all-heart study, the patients who were prescribed to allopurinol with stable ischemic heart disease had no better outcomes compared with the usual care. And it's necessary to add that only the patients without gout were involved in this study. So for today, we have no data to use allopurinol in patients with coronary heart disease without gout. The liver study was another study showed the efficacy of CGLT2 inhibitor, in this case dapagliflozin, in patients with chronic heart failure with mildly reduced or preserved ejection fraction. Dapagliflozin reduced the combined risk of worsening of heart failure or cardiovascular death among the patients with this condition. So for today, we have already at least two medication from this pharmacological group, which are effective in this group of patients with heart failure. The ADVAR study showed that addition of acetazolamide to lock diuretic therapy in patients with acute decompensated heart failure resulted in a greater incidence of successful decongestion. So probably in the future we will use this additional diuretic in the combination with loop diuretics in patients with pulmonary edema. The Panther meta-analysis, which combined 7 randomized trials in patients with confirmed coronary heart disease, showed that risk of death from cardiovascular diseases, myocardial infarction, and stroke was significantly lower in those taking P2 12 receptor inhibitors compared with those taking aspirin. And what is not less important, the frequency of major bleeding in the compared groups turned out to be similar. So probably in the future, we will also change our practice and more often use P2-12 receptor inhibitors. Mostly in this meta-analysis were investigated clopidogrel and ticagrelor, then aspirin in the regimen of monotherapy in patients with ischemic heart disease. Victus study showed that in patients with rheumatic heart disease associated atrial fibrillation, vitamin K antagonism, warfarin therapy led to a lower rate of a composite cardiovascular events or death than rivaroxaban therapy, with a higher rate of bleeding in the rivaroxaban group. So for today, we can conclude that warfarin probably will be still the option number 1 for the rheumatic heart disease-associated atrial fibrillation anticoagulation. Also, the work presented the results of 3 studies of the new pharmacological class of anticoagulants, factor 11A inhibitors, asundexian and milvexian, and the results of these studies showed the anticoagulation with these agents do not increase the risk of bleeding, when they were added to antiplatelet agents in patients after non-cardiac embolic stroke or myocardial infarction. So probably in the next future, this new class of anticoagulants will slowly substitute the other anticoagulants. But let's see some more additional data concerning this group. And of course, there were also presented some new trials concerning COVID-19 and mostly involved the antithrombotics therapy. And all three big studies, COVID, PACT, ACT, and Apollo, was a little charming because they do not support the new options for anticoagulation in outpatient COVID patients, and as well other regimen than low molecular weight or unfractionated heparins in hospitalized patient. In all three studies, clopidogrel, apixaban, aspirin, even in the combination with rivaroxaban, did not improve the outcomes in the inpatient or outpatient COVID patient. And in the end, I would like to keep your attention on the next year congresses. In the end of August, we will, as usually, have the Congress of the European Society of Cardiology in Amsterdam. But also in the beginning of the next year, we will have two biggest Congress of Internal Medicine, the World Congress of Internal Medicine, which will take place in the Dominican Republic in the beginning of February, and also the joint European and International Congress of Internal Medicine that will be hosted by the European Federation of the EFIM in Athens, in Greece, in mid-March of 2023. So that's all from my side for today. Thank you very much for your attention and hope to see you next year.